Good morning, everyone, and welcome. Today is November 3rd, 2021, and I'm pleased to call the second day of our ACIP meeting to order. We will begin with roll call, starting with ACIP members, or only with ACIP members. As a reminder, I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. So this morning, I will begin with Dr. Lair. Dr. Lair?
I'm sorry, something's working on my computer. So Jamie Lair, Hugo Family.
Dr. Lair, I think you.
Family Medicine. Sorry. Jamie Lair, Hugo Family Medicine, private practice, Ithaca, New York. No conflict.
Thank you so much. Dr. Long.
Good morning, Sarah Long, a pediatric infectious diseases professor of pediatrics, Drexel University College of Medicine in Philadelphia. I have no conflict.
Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you, Dr. Paling. Dr. Sanchez.
Good morning, Pablo Sanchez. I'm a professor of pediatrics at the Ohio State University College of Medicine, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital in Columbus. I have no conflict. Thank you.
Thank you, Dr. Sanchez. Dr. Talbot.
Good morning, Kip Talbot. I'm an associate professor of medicine in Vanderbilt University Medical Center. I do adult infectious diseases, and I have no conflict.
Thank you. Dr. Alt.
My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas, and I have no conflicts.
Thank you. Ms. Bata.
Good morning, Lynn Bata. I am the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Bell.
Beth Bell, clinical professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Dr. Brooks. Dr. Brooks. We will come back to Dr. Brooks. Dr. Chen.
Wilbur Chen, professor of medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I have no conflicts.
Thank you. Dr. Sineas.
Good morning, Sybil Sineas. I am an internist and pediatrician, associate professor of medicine and pediatrics at the Warren Alford Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly.
Good morning, Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado, and also an associate professor at the University of Colorado School of Medicine. No conflicts.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor at Harvard Medical School. No conflicts.
Thank you. And I am Grace Lee, Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine, Pediatric ID Doc, and I have no conflicts. Thank you. And I do not believe we have any additional announcements for this morning. So we will begin with the first session of the morning, which we have Dr. Kevin Alt, who is chair of the hepatitis vaccines work group, who will be providing an introduction and overview of this morning's session. So Dr. Alt, over to you.
Thank you, Dr. Lee, and I'm sorry I missed the meeting yesterday because of clinical duties. Next slide, please. After my introduction today, Dr. Mark Wang will present working group considerations for universal adult hepatitis B vaccination recommendations. We'll review how the risk-based strategy has been given over a decade to prove itself, but hasn't panned out because of the complex list of risk factors, many of which don't lend themselves to well-defined, identifiable populations that regularly access care in dedicated locations or the structure of today's clinical practice. The guiding principles for these considerations are to decrease new hepatitis B infections, prevent ongoing transmission, and reduce health disparities. Next slide, please. Health and Human Services has called for the elimination of viral hepatitis as a public health threat by 2030, and the National Academies of Science, Engineering, and Medicine, formerly the Institute of Medicine, has provided a roadmap to achieve viral hepatitis elimination. Their report emphasized the role of vaccination and called for expansion and simplification of adult hepatitis B immunization recommendations. Next slide, please. My favorite graph. This slide illustrates the rates of reported hepatitis B in the US over the past 15 years stratified by age group. The success achieved over the past 20 to 30 years in the US as a result of the implementation of universal hepatitis B birth dose and universal infant vaccination are quite clear here. The purple line and arrows demonstrate that the rate of new infections among 20 to 29-year-old adults has dropped from 3.5 in 2004 to 0.5 in 2019, and the maroon line indicates an extremely low infection rate among 0 to 19-year-olds over the past decade. Unfortunately, that level of success has not been, unfortunately, the level of success achieved among children, adolescents, young adults less than 29 has not been achieved among adults 30 and older. Next slide, please. Looking at the same graphic, now on the left side of this slide, we see a slower rate of decline among 30 to 39-year-olds, as well as increasing rates among adults 40 years and older. It's important to notice displayed on the right side of this slide that about 1/2 of all people with acute hepatitis B, when available risk factor data are considered, do not report any identifiable risk. Next slide. The current risk-based hepatitis B vaccination strategy has taken public health as far as it can take us and will likely fall short of our goal of elimination. In the past 10 years, the total number of hepatitis B cases has plateaued at more than 20,000 estimated new infections every year. And furthermore, rates of new cases are highest among adults 30 and older and have been increasing among the 40 and older adults. Despite 16 different categories of risks, which include blood and sexual exposure, diabetes, being a household contact, or living with someone with hepatitis B, risk screening for vaccination across all those categories is not easily incorporated into clinical practice. It assumes patient recognition of risk and disclosure of a sometimes signifying risk, and it exacerbates health disparities, favoring patients with a higher degree of health literacy and engagement in care. Next slide, please. The working group has been deliberating universal hepatitis B vaccination for several years and is unanimous in proposing that universal hepatitis, and is unanimous in proposing the universal hepatitis B vaccination recommendation. At the fall 2016 ACIP meeting, the topic, universal hepatitis B adult vaccination, was initially suggested to the ACIP as the next step towards hepatitis B elimination. In 2016 and 2017 and 2018, the work group focused on HEPLISAVE and the new hepatitis A policy. Since 2019, the working group has focused its review and discussion, including 15 different working group calls on universal hepatitis B protocol, bringing us to the in-depth presentation of the economic model earlier this year in February 2021. The February 2021 ACIP, at that February 2021 meeting, ACIP members had advised the ACIP working group to move forward with a universal hepatitis B immunization recommendation. Based on that advice, the working group presented the evidence to recommendation and grade analysis at our September meeting, and that brings us to today's consideration. Next slide, please. In the context of all evidence presented and considered over the past 2 years, the subject matter experts comprising ACIP's hepatitis work group have concluded unanimously that a simplified hepatitis B recommendation are needed to reach the national hepatitis B elimination goals. The working group unanimously agreed that the current risk-based strategy needs revision and the majority of her were preferring a universal adult hepatitis B strategy with no upper age limit. Next slide. As Dr. Wang goes through the following slides, I'd like you to keep in mind these scenarios. The working group's preferred proposal is that all adults previously unvaccinated for hepatitis B should receive hepatitis B vaccination. While not preferred, the working group finds an age-based recommendation for all adults 59 and younger as an acceptable alternative. It's important to note that there are no working group members who favor retaining our current risk-based strategy. Next slide, please. Before we move on to the next presentation, I want to thank our experts that are on the working group, and I don't have time to go through all their names, but I will let you read briefly. And next slide. Also want to acknowledge this group of experts that were helpful with today's presentation. I will turn it over to Dr. Lee and Dr. Wang.
Thank you so much, Dr. Alt. Next, we will move on to Dr. Mark Wang, who will present on considerations for a universal adult hepatitis B recommendation. So Dr. Wang, the floor is yours.
Good morning. This is Lieutenant Commander Mark Wang. Today, I'll be presenting considerations for universal adult hepatitis B vaccination on behalf of the Hepatitis Work Group. As a quick refresher, in the US, every year there are 20,700 estimated acute hepatitis B infections and over $1 billion spent on hepatitis B related hospitalizations. There are almost 2 million people estimated to be living with chronic hepatitis B in the US, of whom there's a 15 to 25% risk of premature death from cirrhosis or liver cancer. The work group's goal is to examine Hep B vaccine policy and propose strategies that are most effective at preventing new infections and hepatitis B-related cancer and death. It's in this context that the work group is proposing that the existing risk-based Hep B vaccination strategy is expanded among adults and simplified to a universal recommendation. This slide highlights what that proposal would look like. As you see on the left, risk-based recommendations among adults are complex and include 15 specific behavioral and non-behavioral risks in 3 categories, such as sexual exposure, percutaneous or mucosal exposure to blood, household contact to someone living with hepatitis B, diabetes, or others, such as travel or having chronic liver disease. Moving to a universal vaccine recommendation among adults would serve as a natural extension of existing routine childhood vaccination recommendations. It would serve to collapse the numerous existing adult risk groups on the left into a single recommendation on the right in red text. All adults previously unvaccinated for hepatitis B should receive hepatitis B vaccination. In the next few slides, we'll review a distillation of the prior workgroup discussions on the evidence and experience of patient, provider, and practice factors underpinning this universal proposal. The Hep B immunization strategy has evolved over the past 4 decades. Risk-based strategies were first introduced among adults and perinatally exposed infants in the early 1980s. Then, universal infant vaccination was introduced in 1991, with catch-up vaccination recommendations for all adolescents in 1999, followed by the introduction of universal birth dose among all newborns in 2005. All these steps towards routine Hep B vaccination resulted in large declines in new hepatitis B infections among children and adolescents. However, hepatitis B incidence has plateaued over the past 10 years, with more than 20,000 new infections estimated to occur each year. The past decade has illustrated that risk-based screening among adults has got us as far as it can take us. Initial decreases in new infections have stagnated. Rates of acute infections are now highest among 30 to 59-year-olds, and rates have actually increased among adults 40 years and older, indicating that we're losing ground. We cannot eliminate hepatitis B in the US without a new approach. This slide summarizes the limited Hep B vaccine coverage among adults in 2018. Overall, coverage was 30% for adults 19 years and older. Reported coverage rates were likewise low across risk groups, including travelers, people with chronic liver conditions, and people with diabetes, with particularly low rates among older people with diabetes. Surprisingly, among healthcare personnel, Hep B vaccination coverage was only about 67%, which is far short of this group's Healthy People 2020 target of 90%. This is Hep B vaccination coverage in adults with identified risk factors. Coverage is suboptimal across all age groups and is lower among older adults. The youngest adult age groups might have received protection under the Universal Childhood Hep B recommendations of 1991 or the catch-up recommendations of 1999. But as the age groups get older, coverage rates steadily drop. Less than 20% of older adults with identified risk report having been vaccinated. It's worth emphasizing here that this suboptimal Hep B coverage data is among people with identified risks. And it's important to recall that only 1/3 of people with reported acute hepatitis B actually reported any risk factors. For the remaining 2/3 of reported acute infections indicated in yellow shading here, the current risk-based vaccination strategy among adults provides no advantages in identifying and vaccinating people who had either denied any known risk or simply lacked any risk data. Multiple health disparities could be improved with a universal Hep B recommendation. Among children and adolescents, acute hepatitis B infection rates in all races and ethnicities converged to a lower rate when a universal vaccination strategy was implemented for children less than or equal to 18 years old. Right now, acute infection rates among Black American adults are up to 3 times the rates of Asian Pacific Islander and Hispanic groups. Racial and ethnic disparities remain in who gets infected with hepatitis B virus. Further, the work group recognizes that the risk for acquiring hepatitis B is dynamic throughout one's lifetime, meaning that a person might move in and out of risk categories. Exposures, whether recognized or not, might change over time. The current risk-based Hep B vaccination recommendations favor patients with access to health care over their lifetime, trust to disclose often stigmatizing risk factors to the provider, awareness of risk, and a high degree of health literacy. Hep B vaccination provides lifelong protection whether you develop diabetes or end up in an assisted living facility, share a home with a person with hepatitis B, or choose to travel. The work group reasoned that it would be better to be vaccinated before people get exposed and that a universal adult vaccination recommendation would promote health equity. We distilled ACIP feedback from the February and September sessions into 3 overarching questions to help drive decision-making today. First, can universal recommendations increase vaccine uptake among people with risk factors? The work group said yes. We'll review some of the deliberations. Next, is a universal Hep B vaccination recommendation an effective use of resources? The work group said yes. We'll review how the economic analysis presented in February 2021 indicates that the recommendation is within the bounds of reasonableness, especially after appreciation of the model's conservative assumptions on vaccination coverage. And finally, should the proposed Hep B recommendation include all ages or revisit adding an upper age limit of 59 years old? While the work group unanimously prefers moving away from the current risk-based strategy, the majority believes universal recommendations should include all ages. I'll note here that the 59-year age cutoff was selected to align with the Hep B diabetes recommendations. To address the first question, can universal recommendations increase vaccine uptake among people with risk factors? The work group recognizes that while there's no perfect parallel, several vaccine-preventable diseases provide useful comparison points, common themes, and rationales that ACIP has discussed in the past. In 2010, flu vaccine coverage of adults with high-risk conditions was 28.6%. Universal flu recommendations were then promulgated that year. 10 years later, vaccine coverage has nearly doubled to 51% for people with high-risk conditions. Pneumococcal vaccine provided a different sort of example, where in 2018, there was a risk-based cohort among 19 to 64-year-olds at the same time as a universal cohort among adults 65 years and older. Under risk-based recommendations, just under a quarter of 19 to 64-year-olds at increased risk were vaccinated, while adults 65 and older under the universal recommendation were vaccinated at nearly triple the vaccination coverage. To bring it back to Hep B, the work group looked at birth dose recommendations. Shifting from risk-based to universal in 1991 resulted in increased coverage among all newborns. Birth dose coverage went from half the newborns in 2005 to almost 80% in 2018, shy of the Healthy People 2020 target of 85%. The work group felt strongly that these and other examples not shown provide compelling examples of how universal recommendations increased vaccine uptake among people with risk factors, and therefore answered this question as yes. The work group summarized limitations and advantages of universal recommendations to increase Hep B vaccine uptake. First, the limitation is that future increased vaccine uptake is unknown. However, that magnitude can be inferred from public health experience with other vaccine-preventable diseases. On the right are the advantages. For patients, groups with high-risk behaviors might be concerned with stigma, which reduces motivation to get indicated Hep B vaccines. A universal recommendation would facilitate patients' access to routine standard of care by not requiring patients to recognize and disclose risk. And even though current indications allow for vaccination among anyone who requests it, we've already demonstrated that only 1/3 of people who reported acute hepatitis B in the US report any risk factors. Furthermore, about 2/3 of the people in the US with chronic hepatitis B infection are estimated to be unaware of their own infection, precluding them from getting treatment for their own health or informing their contacts of possible transmission risk. For providers, a simplified recommendation facilitates implementation and empowers clinicians to offer vaccination. It shifts the onus to vaccinate from the patients to the providers, and at the same time makes it easier for providers to help their patients. The work group drew parallels with opt-out public health policies that have shown success in lowering barriers to care, such as universal Hep C and HIV screening among adults, as well as routine HIV, hepatitis B, hepatitis C, and syphilis screening during pregnancy. Simpler clinical implementation would likely result in increased vaccinations for healthy adults and adults with risk factors who've not yet been vaccinated. We showed data in September published by Dr. Daly and colleagues, suggesting that even providers have trouble processing that long list of risk factors during a busy clinical session. For public health and clinical practice, universal Hep B recommendations would contribute to larger efforts to eliminate hepatitis B nationally and globally. And underlying all these advantages is that it facilitates health equity goals, reducing disparities and inequities in accessing Hep B vaccination. Based on the points just discussed and the evidence to recommendation framework provided in September in a work group straw poll, 100% said yes. Universal Hep B recommendations would increase vaccine uptake among people with risk factors. Second, is a universal recommendation an effective use of resources? The cost, or ICER, was calculated at $153,000 per quality gained. Please note that if a higher vaccination coverage is achieved, then this anticipated cost does get lower. For example, with 20% additional coverage in people with increased risks, the cost per quality drops to $135,000, illustrating the benefits of increased access. The economic model presented in depth at ACIP in February was used to estimate the health improvements of universal adult Hep B vaccination, which would reduce acute infections by 24%, reduce deaths by 23%. The work group had selected a conservative base case in the economic model. After the February presentation, several committee members did consider the model assumptions to be too conservative because the base case did not assume any increase in additional vaccination among people with risk factors. The work group agrees with the committee with the rationale from the preceding slides that higher Hep B coverage could likely be assumed in this population, which would then lead to lower cost estimates than the conservative base case costs shown here, and would increase access at the same time. Sensitivity analyses presented in February are available for these assumptions of increased coverage. Is universal Hep B vaccination an effective use of resources? In a work group straw poll, 70% said yes. The remaining 30% said probably yes. Third, should the recommendation include all ages, or should it include an upper age limit at age 59? Let's look at a sub-analysis with the Hall economic model with inclusion of the upper age limit in the center column. The ICER is lower, and the number needed to vaccinate is lower, and less doses given with the upper age limit. There's a similar reduction in infections. Despite the cost, the work group saw many advantages of the universal recommendation for all ages. The upper age limit did initially receive some support on the work group, but when presented to ACIP as an option in February, the committee discussion seemed to support universal without an upper age limit. Based on the committee's subsequent September feedback, the work group revived this age limit scenario for consideration today. First, the limitations on including adults of all ages, as discussed by the work group. There's a relatively lower incidence among the population over 59 years, which yields a higher cost, or ICER, to protect older populations. With an upper age limit, specificity would be improved by clearly defining an age group of interest. But the work group also reasoned the trade-off is that a complex, risk-based recommendation would still be required for adults over 59 years, with all its inherent flaws as just discussed. A key unknown is the exact impact on vaccine uptake. The work group does believe, with supporting evidence just shown, that it's likely that uptake would increase, but it's hard to say exactly how much. As a committee member asked in February, would we be missing opportunities to vaccinate older adults by maintaining barriers to access at a time in their lives when older adults might otherwise be going in and seeing their providers? On the right, the main advantages of a recommendation to include adults of all ages. Hepatitis B still causes significant disease in older adults, so these individuals over the age of 59 still deserve protection. Many adults will age into one of the risk groups, like diabetes, kidney disease, or certain lifestyle changes, so it's better to vaccinate them early. If a large portion of adults already have or will eventually develop one or more risk factors, why wait until they become sick with comorbidities that might actually lower their response to vaccines just when they need it most? Implementation will be less complicated without the additional age cutoff, so the work group preferred a recommendation that's more likely to be followed by patients and providers. And again, improved health equity is sought across the ages in this case. In a work group straw poll, 56% favored a universal adult recommendation to include adults of all ages. They felt that a one-time completion of HepB vaccination provides lifetime protection. For many adults, the absence of a risk factor today doesn't mean that they'll be without risk for the rest of their lives, and that people respond better to vaccination at younger ages and before comorbidities or a risk factor develops. So why not vaccinate people before they acquire that risk factor and can transmit the virus if infected? To recap the work group preference, no one on the work group supported staying with the current risk-based recommendations. 100% of the work group preferred a universal adult Hep B recommendation, with the majority supporting inclusion of all ages. To summarize, in the context of the call from HHS and National Academies of Science to eliminate viral hepatitis, there are multiple examples and evidence where universal is preferred to risk-based approaches to lowering barriers to vaccination. This is in line with public health principles and practice. The work group reviewed these examples, along with the previously shown hepatitis B infection rates, dynamic risks of hepatitis B over everyone's lifetime, and health equity observations. The work group concluded that by relying on the current risk-based recommendations, focusing only on the slow, bottom-up approach of vaccinating all children who will then take their immunity with them when they reach adulthood would be a disservice to a large portion of the U.S. population. Plus, the current risk-based policy creates obstacles for the provider to identify risk and for the patient to self-advocate, which is a particularly challenging barrier for people in vulnerable and medically underserved communities. So what else is different this time compared to 1982, when risk-based Hep B recommendations were first introduced? Today, we have a growing toolbox and new access points for vaccination to eliminate this potentially fatal virus. There are now 2 single antigen 3-dose vaccines available, safe, effective, and with long-term immunogenicity. 1 2-dose vaccine, which is safe and effective. There's also 1 combination vaccine and 1 vaccine in the pipeline that you'll hear about at an upcoming ACIP session. The work group concluded that the universal recommendation would allow the U.S. to leverage this growing toolbox for public health and equity goals. With an eye towards implementation, this universal recommendation dovetails with a couple recent developments: the ongoing expansion of viral hepatitis surveillance, renewed focus on vaccination delivery, improved integration of services, and expanded immunization venues. Plus, by late 2022, we're anticipating CDC recommendations for one-time hepatitis B screening guidelines for all adults. Hepatitis B is vaccine preventable. Safe, effective, cancer-preventing vaccines have been available for over 40 years, but the current risk-based Hep B vaccine policy has clearly become a barrier to public health objectives. For these reasons, the work group believes a universal hepatitis B vaccination recommendation among adults would provide the best chance of achieving hepatitis B elimination goals in the U.S. This is the language of the proposed recommendation for the ACIP consideration. All adults previously unvaccinated for hepatitis B should receive hepatitis B vaccination. Thank you.
Thank you, Dr. Wang. And I just wanted to take a moment to ask Dr. Brooks, who joined us earlier during the presentation, if he would please state his name, his affiliation, and any conflicts of interest.
Yes, thank you. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation. No conflicts. I've been on since the first presentation with Dr. Ault. Thank you. Dr. Grace.
Thank you, Dr. Brooks. And with that, let me look to the work group leads and ask, may we open this presentation for questions now?
Please.
Okay, great. So this presentation is now open for questions. And I see several hands raised. So Dr. Chen.
Good morning, and thank you, Dr. Wang, for getting us through this detailed discussion on the Universal Hepatitis Program. One thing, could you elaborate a little bit more? I think in your last slide, you made this statement, but I didn't see the bullet point. So maybe you can elaborate again on, you mentioned that there will be a single time point serologic testing in the population. And I think that kind of process would dovetail very nicely with the universal vaccination program. Can you tell us a little bit more about it? Maybe I missed it, and I only heard that in the last, when you were discussing your last slide, but can you talk a little bit more about this serologic testing program?
Hi, Dr. Chen. Thank you. This is Dr. Wang. The work group quickly realized early in the course of these discussions that even though the vaccine policy is the scope and the focus of the ACIP work group, that the screening guidelines, from a practical standpoint, would have to go hand in hand with a universal recommendation. And I might defer to Dr. Nelson to speak more on that.
Hello, this is Dr. Nelson. So CDC testing or screening recommendations have been drafted. It's a separate process following the CDC evidence review. This will go to peer review and public comment. But what has been proposed is screening with using 3 tests: surface antigen, core, and antibody for all adults over the age of 18. And this is anticipated to be recommended for later in 2022. Thank you.
And it sounds like it would be a one-time test for 18 and above, but will there be perhaps a frequency every 10 years thereafter or upon a certain age? Again, just trying to understand how a testing program, a screening program, would really, again, dovetail nicely with a vaccination program when you are rolling out a universal program to help people understand really the gravity of this disease.
Thank you. So that has not been determined yet. It would be a one-time testing, and then for persons with ongoing risk, then the plan would be to have intermittent testing that might be based on provider guidance, or maybe 1 year. That hasn't been specifically determined, but it would be overall routine one time, and then for persons at risk, additional testing might be warranted.
Thank you. And Dr. Chen, if you have additional questions, please raise your hand again. Dr. Long.
Yes, thank you so much. I wonder if you'd go back to the slide that you showed us, the number needed to treat, Dr. Wang. Thank you. When you showed us the incidence and new acute infections, and we saw a really pretty low 60 and over. So I'm surprised that the number needed to vaccinate was relatively low. It was 200 and something in the whole group and 300 and something. And I just want to look a little bit more carefully and ask you some questions how much modeling and what the assumptions were in that group. Can you possibly put that slide up again?
We're working on, oh, there we go. Okay, thank you.
Oh, there you go. Okay, all righty. Okay. Yeah, that surprises me a little bit. You know, when we think about immunizing people over the age of 60, and you ask the question, what risk are they to themselves if they get hepatitis B? Of course, they could get acute hepatitis B that was substantially impactful, but they probably don't have the longevity to have the if they have chronic disease, which is a minority of them, chronic infection, they probably won't live long enough to get cirrhosis and cancer from hepatitis B. You can correct me if I'm wrong on that. And then the question is, what risk are they to others? It seems like that would be pretty darn small. So I'm wondering what assumptions you made, and can you help me understand why that number needed to vaccinate to avert an acute infection is so relatively similar and low for the age group that seems to have such a low incidence? I already know from yesterday, you know how to do your math, so there must be something I'm missing. Thank you.
Hey, Dr. Long, thanks. This is Dr. Wang. I can ask Dr. Hall to comment as we have the modeler on, but I can say that as for at that age, in those ages, I think the thing the work group is focused on is this concept of dynamic risk and the heterogeneity of the nature of those risk factors, and not being able to predict how long someone's going to live, if people live that long, what sort of risk factors, risk groups they might enter, whether it be behavioral or non-behavioral. As to the technical aspects of a number needed to vaccinate, I don't know, Dr. Hall, are you able to comment, or our ACIP health economist, Dr. Leidner?
Sure, if you guys can hear me, this is Eric Hall. And I can comment a little bit on how we calculated this number needed to vaccinate within this model. So there's a couple key things. One is that our analytic horizon of this model is the lifetime of the initial cohort of individuals that's vaccinated. And so this number needed to vaccinate applies to like a static cohort of adults in time moving forward, which is something we had previously discussed. And then second, I think as you mentioned, this is the number needed to vaccinate within this current cohort of adults going forward in order to prevent an acute infection. And so this, calculation, I think you said you looked at the math yesterday, is simply, the difference in the number of people protected by vaccination divided by the difference in number of infections between the two strategies. And so in this setting, it's pretty much has a direct tie to the incidence of acute infection within these different age groups. And I just say that because that's slightly different than other types of vaccination modeling studies, which incorporate a dynamic risk of infection. And so there's herd immunity type effects, and that number needed to vaccinate can change as you get a higher proportion of people vaccinated and your prevalence of disease goes down in the population. I don't know if Andrew Leidner wants to add anything to that.
I wonder if you could just separate out what the number needed to vaccinate would be for those 60 and older, and the number needed to vaccinate to prevent a death through 59 and from 60 and above. And I see there are so many other hands up, but I still can't quite wrap my head around, this particular age group of 60 and above and their risks to themselves and others.
Okay, this is Dr. Wang. Thanks, Dr. Long. That would be, we do imagine that it would be much higher, as I think you're alluding to, and if we just look at that single age group. So yes, the ICE would be higher there.
Thank you, Dr. Long, for those questions. Dr. Lair.
Thank you. I have a sort of long comment as to why I'm suggesting that we have an upper age limit for this recommendation. I want to thank everyone for their hard work. I recognize that this is a process that's gone on for several years, that I'm a relatively new member, and I'm just one voice. I agree that the risk-based strategy has taken us as far as we can go, and the universal strategy is appropriate, but I have concerns about having a recommendation for adults over the age of 60. And so I agree with the minority of the working group that it should be just for under people age 60. I have several reasons. If you go back to slide 18, I feel there's diminishing returns. If you look at the last two lines down here, last three lines, if you only give it to people under 59 years old, you'll be giving 298 million doses. If you give it to all adults, you'll be giving 352 million doses. That's an additional 54 million doses, an extra 18%. You're increasing the percent of people who are protected by 28%, but you're reducing the acute infections by only 1%. So that to me seems like it's diminishing returns. I'm also concerned about the cost. The $153,000 base case for all adults is reasonable, but when you break it down under Dr. Hall and Dr. Rosenberg's presentation from February, when you break it down by age group, the 40 and 50-year-olds have a cost which is, looking here, $58,000. Whereas if you go to the over 60-year-olds, the quality, the ICER is over $500,000. And that just is higher than I'm comfortable supporting. And I think this is why the past recommendation for hepatitis B vaccination for diabetics over age 60 was not a routine recommendation in 2011, because it didn't appear to be cost effective. I also feel that all adults over age 60 don't need the vaccine. As Dr. Long just said, if an adult at age 80 or 70 gets an acute infection, there's a small chance of fulminant hepatitis, but the chance that she's going to have chronic disease, only about 5 to 10% of people with an acute infection turn into a chronic infection, and it would take 20 years before that chronic infection would affect her health with cirrhosis or cancer. So I think that simplicity is a valid goal. I understand that there are adults over age 60 who have risk factors and might not get vaccinated because the system is not perfect and the risk-based option does not always work. But I simply think that recommending for all adults is not a good use of resources and is not the best recommendation. And so I look forward to hearing from my colleagues to get their perspectives on my thoughts. Thank you very much.
Thank you so much, Dr. Lair. We will move on to Dr. Paling.
All right. So first of all, thank you for this wonderful presentation and trying to break down and address the questions that have been raised before. It's very clear that the current recommendations are inadequate, and very glad we're going to be moving forward. One of the things I appreciate that you brought up was the benefit of the childhood vaccinations and the elimination of disparities from a universal recommendation. One of my challenges I have as an adult is I'm a person that knows more about my vaccines than my provider, and I'm the one that's having to tell them what I've received, because there is no universal adult vaccine registry. And so I wanted, and that's an important part of the success of the childhood vaccination. So I'd like to give you a chance to talk about that and how we might overcome that barrier. And then I have a second question afterwards.
Dr. Wang?
Sorry if I understand the question correctly. It's about moving from childhood to adult vaccination and the successes in childhood vaccination. Is that right, Dr. Paling?
The question is, an essential part of the success of the childhood vaccination is that we have a registration. We have a registry. And I know all the vaccines a child has had, regardless of where they've gotten their vaccine. Where as an adult, in my experience, I'm the one that's telling people what my vaccine coverage is, because there isn't a universal registry for adults. So how are we going to overcome that?
Is Rebecca Coyle on?
You know, thank you for asking the question, Dr. Paling. Maybe what we'll do is we'll ask if our colleagues from the American Immunization Registry Association would be able to comment, it's sort of after a few more questions. Did you have another question that you would like to ask too?
I do have another question. My second question is, when we go back to that number needed to vaccinate, I'm struggling with the over 60 as well. And it looks like a minority of the 20,700 cases occur in persons over 60. And the way I got there, if you can put up the number needed to vaccinate, is I believe that if we're at, it's another way of doing the same math that Dr. Laird just did, is that we can prevent 93% or 23% of infections at less than 59 and 24% if you do everybody. So 96% of all infections are prevented at less than 59. Is that correct? Thank you.
This is Dr. Wang. Dr. Hall, would you like to comment on the economic model?
Yeah, I'm trying to think about if that math translates exactly that way. To further describe what these two numbers are here, in our base case scenario, which we didn't necessarily go into what that means in this presentation, but we did in the previous presentation, which is 50% vaccination coverage among those that are previously unvaccinated or not indicated for vaccination. That leads to a 23% reduction in acute infections if we just apply that to those less than 59, and a 24% reduction if we apply that to everybody. I'm not sure that entirely translates to the direct relationship of number of infections that occur in these different age groups, because again, we didn't go into in this presentation, but this model separates out persons that are high risk or non-high risk, and those high risk individuals have the same vaccination coverage among or in the comparison strategy and the intervention strategy. And so that's all to say that I agree with the majority of the infections that would be prevented by this, as we see here, are in those that are under 59 years of age or younger. I'm just not sure. I'd have to think a little bit closer if we can actually estimate the number of infections occurring within age groups based off of these numbers here.
Thank you for that response. And actually, I'm going to turn the microphone over to Dr. Posner, who will respond regarding your other question, Dr. Paling.
Good morning. This is Sam Posner, Acting Center Director for NCIRD, and thank you for that question. And I want to talk a little bit about how we've really improved increased the number of adult vaccines in registries over the course of the pandemic, and we've really opened up and made a lot of progress in that, and we're working to increase our ability to document other adult vaccines as well. And, we are working also very much on a more comprehensive adult immunization program, and feel that will also support reporting to the registries. Thank you.
Thank you. We'll move on to Dr. Talbot.
Yeah, I had a couple comments. I am First, I'm just thrilled that we're looking at doing a universal for adults. This will really move this program forward. This is a disease with a lot of disability and mortality, and to see it gone would be fantastic. I do want to point out a couple things that were mentioned in the presentation, which I think are key and important for those that are over 60 years of age, and will help explain how adults over 60 are actually very good vectors. And so I think this will help answer some of the questions about those who have qualms about those over 60. We see a fair number of hepatitis B outbreaks in hemodialysis centers. Unfortunately, by the time we identify someone as needing hemodialysis, they're very unlikely to respond to Hep B. In fact, there are multiple protocols to improve the response to Hep B vaccination in those with renal failure. If we could capture this group prior to their renal failure and vaccinate them as adults, we would reduce the risk of these outbreaks occurring in these facilities. Second, in facilities like hospitals and nursing homes, we use glucometers, and there are lots of documented outbreaks of hepatitis B due to these glucometers. Hence, it is critical that we begin to vaccinate those older adults who are in the nursing home or hospitals so that they not only not capture it, which is that 1% everyone's worried about, but don't spread it, which is probably a good portion of those less than 60. So I think they are an incredible risk for spread and that I think is highly under-recognized. But the public health people on this panel could probably talk about the cost of time and money and people that investigate each of these outbreaks. And that is probably not included in that over 60 analysis. Thank you.
Thank you, Dr. Talbot. Just go back to my participant list. Apologies.
Tracy, can't hear you.
Oh yeah, no, sorry. Can you hear me now?
Yeah.
Okay, great. Thank you. Dr. Bell.
Yes, thank you. I have a couple of comments to make, and then perhaps we'll ask Dr. Wong to expand on a couple of things. I certainly agree that it's time to reevaluate the strategy and recommendations for hepatitis B vaccination. However, I'm concerned that, in general, we don't do such a great job with adult vaccination in the United States. And hepatitis B is a disease where the risk is not evenly distributed among the population. And as we've heard, many of the risk groups are disadvantaged populations. And so, to me, if we are going to recommend a universal hepatitis B vaccination for adults, what the success of this program is really hinges on implementation, and implementation which will allow for vaccination of the right people, people who are at risk. And I don't see that, I'm not a big subscriber to the idea that anybody could become at risk at some point in their lifetime. And so that means, I think, if we're really going to focus on the right people, the people that are at risk, to get them vaccinated with a simplified recommendation, that really means, I think, all of us are getting serious about paying attention to those issues. So it doesn't remove the need to think about who is at higher risk for hepatitis B. And I am somewhat concerned about a lot of people who who are not at risk and don't need to be vaccinated, getting vaccinated and continuing to not see an impact on disease incidence because we're not vaccinating the right people. So in that regard, I think I was interested in some of the other comments that Dr. Wong made about other strategies and programs that CDC is considering and working on, which might show that we are heading in the right direction in terms of implementation, in my opinion. So I might ask him to comment on that. And then I did, Dr. Lee, if you don't mind, I do have one other point to make.
Of course. We'll let Dr. Wang respond, and then we can come back to you, Dr. Bell.
Hey, thanks, Dr. Bell. This is Dr. Wang. Let me just pull up this slide here. It's a lot here, but it's a direct quote from MMWR in June 28th, 2002, so nearly 20 years ago. It basically lays out a roadmap of kind of what Dr. Bell is saying in the middle in the gray text, and I'm not expecting you to read all of it, but the difficulty in identifying candidates for vaccination before they become infected, looking at STD clinics, HIV counseling testing sites, correctional facilities, and drug treatment clinics, work with state and local public health departments to integrate comprehensive hepatitis prevention measures, including Hep B vaccination, into programs providing services to persons at risk for HBV infection. And so this was early this century. The risk-based strategy has had a long runway, a long time, but we've seen the plateau, as we showed earlier, in the risk-based strategy getting us as far as it can get us in terms of, without having a universal Hep B adult vaccination strategy. Dr. Nelson or Dr. Wester, would you care to comment?
This is Dr. Nelson. I guess the only comment is, if you look at settings where really streamlined efforts have been made, such as in dialysis clinics, you will see an substantial increase in coverage. However, that dedicated effort within the specific setting is needed in order to reach the level of coverage near to where we're trying to go.
And this is Dr. Wester. I would just simply add that, yes, in addition to a universal approach, making implementation easier in settings where people are engaged in care, that there would also be accelerated efforts to ensure that the universal approach is implemented in high impact settings as well. Thank you.
Thank you. Dr. Bell, did you want to ask your other question?
Yes, thank you. So two things. First of all, I think that one important component of what we are now talking about, that is using the universal recommendation in a way that's going to most help us get to vaccinating the people are at risk. If we are going to do that, achieve HHS elimination goals, implement the roadmap of the National Academy of Medicine and all these other groups that have been clamoring for HBV elimination, there needs to be funding. And I think that, it's just worth saying that these kinds of efforts need to be funded. And that just hasn't happened in the world of viral hepatitis and hepatitis B in particular. And I hope that the policymakers who have the purse strings will put some teeth behind things like a call for elimination. So that's that. Then the last thing I want to say just briefly is I agree with Dr. Lair about the age cutoff of this recommendation. I think that the cost is high for people over 60. And I think that while it's certainly true that there are outbreaks in dialysis clinics and among diabetics in nursing homes because of glucometers, I would hope actually that we could do something about infection control, which is the root cause of these outbreaks, and not have to vaccinate, recommend vaccinating everybody over 59 because we can't seem to do what's necessary in terms of infection control. So that would be my preference. Thank you.
Thank you, Dr. Bell. And as someone who has worked in infection control, I wholeheartedly agree with your last comment. Dr. Sanchez.
Thank you. I want to reiterate and really a lot of the comments that have been made. To me, certainly universal immunization is very attractive, and certainly our ultimate goal, and certainly as pediatricians and neonatologists, that is our goal. That is our current practice, which I heartily recommend. But I'm just wondering if 59 is really the correct cutoff. 59 years of age is because adults with diabetes that's the cutoff that was done in 2011. Because, I mean, it doesn't seem to me like a 90, 95-year-old, 85-year-old may be the person who really needs to be vaccinated. And that's what would happen with this universal recommendation. So I tend to agree that the age cutoff needs to be re-looked at, and maybe not for universal everyone, but maybe a higher, I'm just asking also whether a higher age cutoff may be better. I want to also ask a little bit about the serologic testing that was brought up by Dr. Chen. So I'm a little bit confused. So would the plan be that there's a universal screening and testing of individuals before the implementation of this program? And then, of course, if they show past evidence of hepatitis B infection, then they would not be vaccinated. So I just have a question on that. And then, of course, the importance of the registry. But really, my two comments would be, is 59 the right cutoff age? And also just clarification on the serologic testing would be great. Thanks.
Thanks, Dr. Sanchez. This is Dr. Wang. The 59-year age cutoff was chosen to looking at in terms of the principle of trying to simplify implementation for providers so that they can help patients in a more streamlined fashion. So that was chosen to align with 59 with the diabetes recommendations. The work group recognizes that there were other age cutoffs, but this is out of the work group's purview in terms of outside of hepatitis B vaccinations. The other thing I'll mention is that work group did tussle with the ICERs at this age group, but then looking back at the reported acute hepatitis B by age group, they wanted to avoid, this sort of anchoring bias that just because the greater or equal to 60-year-old in that pink line on the bottom, just because it's the lowest, doesn't mean they wanted to throw that group out. What they're aiming for is the pediatric 0 to 19 years old to eliminate hepatitis B. And without a universal Hep B recommendation for all ages, the majority felt that we couldn't do that. The other thing I'll mention about the cost, we've seen this slide a few times here. The total incremental cost of $32 billion, $22 billion. That's over. It's footnoted here, very small, but it's over the cost of an entire cohort. So that's about 30, 35 years. Dr. Hall, correct me if I'm wrong about that, but I imagine it's the lifetime of the cohort. And just weighing that with the slide I showed in introduction, the $1 billion of greater than $1 billion cost of treating hepatitis B per year. So just looking at those two items to help, I don't know if that helps put things in perspective for some of the work group, for some of the committee. And as for the screening, let me switch back to Dr. Nelson.
Hello, this is Dr. Nelson. So the plan would be to continue with the current pre-vaccination testing recommendations as they currently are. When the CDC screening guidelines are published, then we would go back and revise pre-vaccination testing guidelines to align with the CDC recommendations for screening. So it would be a test vaccinate approach. And then one other comment is just, we do plan to use clinical considerations, clinical guidance within our policy to address, could potentially address some of the questions that have come up regarding vaccinating, for elderly or other persons above a particular age limit. Thank you.
Thank you. We still have a number of hands raised, and we will get through all of them. I'm going to actually call on Dr. Cotton, Dr. Paling. I'd like to add something. And then I see that we have a couple of colleagues who would like to just provide additional comment on the registry issue. So, Dr. Cotton.
Thank you. I'd just like to highlight that as a clinician who sees hundreds of patients as they're being evaluated for organ transplant who have both kidney and liver failure, I am shocked at the number of people who are on dialysis or who have cirrhosis who are not yet vaccinated against hepatitis B. And I know it has been a recommendation for dialysis patients, yet many dialysis patients allow patients to just defer vaccination. So we have a very large population, some under the age of 60, many over the age of 60, who could really benefit from vaccination. And I would extend that to the larger population when they are more likely to undergo a better response to vaccination, especially if it were given at a younger age. I do have some concerns about implementation and how we are going to best reach the population that could most benefit. I think it's hard to, they may be a population that's less likely to seek healthcare. And I think the current recommendations for vaccines to be given either at 0, 1, and 6 months or in the form of Heplisov a month apart might be quite challenging to clinicians and to patients, to have to go back to the doctor several times or to go to a clinic or wherever it might be. So I'm wondering if there might be any adjustment in the hepatitis B vaccine recommendations to kind of provide a more loose time frame for clinicians and patients so that they can meet the goals. Otherwise, it does add a significant burden to many doctors' offices and to the patients. And then I share the struggles of people who've mentioned the greater than 60 age cutoff, but I think it's really hard with respect to equity and people with risk factors or who don't yet have risk factors to not include the people over 60 in the current recommendations. So I just wanted to emphasize those points. And again, I remain shocked at the number of people who are poorly vaccinated against hepatitis B. So I think this is a very strong and favorable move. Thank you.
Thank you, Dr. Cotton. Dr. Paling, you've had your hand raised briefly. Did you want to add any comment?
Yes, real quickly. I would be very interested in looking at the racial breakdown, racial and ethnic breakdown of hepatitis B disease over the age of 60, and trying to understand how much that would address.
This is Dr. Wang. We don't have that level of granularity at this time, but what we do have is this incidence of acute hepatitis B by race and ethnicity and year. I showed the 2004 to 2018, but the point made earlier was that the childhood universal recs help the racial and ethnic disparities converge. And I'll go when we zoom in a little bit more to the present day. Getting closer, but there's still ways to go with the 3 times, the triple the infection rates in some racial and ethnic groups. Over.
Okay. All right. Thank you. And I understand there's more conversations about the registry because that's a very big point for me for adults. Thank you.
Thank you. And actually, I just wanted to give, maybe I'll pause here and give Rebecca Coyle a moment to respond if she'd like to.
Sure. Thank you, Dr. Lee and Dr. Paling. Just to, I think, further elaborate on what Sam Posner mentioned. So I think what's important to note is that the immunization information systems, the same systems that are capturing childhood and COVID vaccines, are really lifetime registries. So they are capturing birth to death, all of the vaccines that are being administered out there. So I think there's a couple of other key pieces. So prior to 2020, when we were starting to vaccinate adults for COVID, we had 60% of all adults captured in an immunization information system. So we anticipate that that has increased dramatically, meaning that a lot of the adults that would potentially receive hepatitis B vaccines would already be in the system, and that their hepatitis B vaccines would just be associated with their already existing record. I think there are still gaps to close in terms of capturing or having all all providers that are vaccinating adults reporting to an IIS. So that continues to be a challenge, but I would say there have been significant strides in closing that gap over the past year, particularly with COVID vaccines, and recognizing that high priority was on adults to begin with. Pharmacies are a great reporter of immunization information data to immunization registries. And I think just to reiterate, I think more adult providers are now aware of immunization registries and are also connected and reporting vaccines to those registries. So thank you.
Thank you for those comments. I will just add in, one question and one comment. And my question is, did the cost effectiveness analysis incorporate the costs of a screening program?
Yeah.
Oh, sorry. I don't know if Dr. Hall or someone from the economics team would like to answer that.
I'm sorry, it cut out just a little bit. What was the question?
Did the models incorporate the costs of a screening program as a component of the vaccination program?
So it did not incorporate any additional screening as part of the universal vaccination recommendation. It kept the same screening recommendations in place, which would be amongst what we included in our model as the quote high-risk individuals.
Okay. Yeah, I just think that when we're looking at those numbers on slide 18, they're not reflective of what's intended, which would be, you're incorporating the screening program into this. And I imagine that that's actually going to, look differently, in particular for the 60 and older population, where you can imagine that you're going to gain less by screening and increase cost and sort of that, time that you need to be able to then get that back and then vaccinate. So I guess I would just say that this is probably a conservative estimate of what the cost effectiveness would look like. And it makes me even wonder whether or not you would universally apply a screening program across all age groups, or would it just be more cost effective to vaccinate in some age groups, for example, as opposed to trying to universally screen everybody and then vaccinate?
This is Dr. Nelson. Just to say that we did do those cost analyses for the screening, but we're not prepared to present those in the ACIP forum.
And then I just wanted to highlight one point that, I agree with many of the points that my colleagues made, but there is one point I really wanted to emphasize, which is Dr. Bell had mentioned the importance of making sure that we don't detract efforts away from making sure that we're really trying to do outreach to risk-based groups and how important that is. We don't want to also assume that I recognize that you as a team are seeing this as one part of a many-pronged strategy to try and address this and to try and tackle Hep B incidence rates. But it is sometimes easier for us to go back to the generalization or the universal recommendations as the default, and not always have the funding, the effort, the focus to continue to make sure that we are enhancing our outreach in difficult to reach communities. We haven't figured a way to tackle that yet, and I would just encourage us to, as Dr. Bell had mentioned, ensure that we're allocating funding and effort in those areas, because those are going to be most impactful, even though they're the most difficult to reach. But recognize the benefit of a complementary program that would also enhance our ability to capture this population. Okay, thank you. I'm going to go, and I want to make sure we capture all the liaisons. And first, I just want to say thank you to all our liaison members who have raised their hands. We really appreciate your input on all of this, and I recognize some of you are work group members as well. So we look forward to hearing your comments. Dr. Schaffner.
Yeah, thank you, Dr. Lee. The National Foundation for Infectious Diseases first thanks Dr. Wang for his comprehensive, compelling, and we think convincing presentation regarding universal vaccination. In 1991, when the U.S. began a strategy to eliminate hepatitis B virus transmission through immunization, since then, hepatitis B infections have declined substantially, but as we've seen, They persist and indeed have increased in parts of our adult population due to low adult vaccination rates and also the opioid crisis. It's clear that most of the discussion, at least as I understand it, has focused on individuals. But universal coverage also will eliminate, in addition to those complicated discussions that doctors would have with patients, we agree with retiring the risk-based approach. It would eliminate cost barriers and increase equity. My last point is to go back to a concept raised by Dr. Alt. He noted the National Academy's determination, their goals to actually eliminate hepatitis B virus transmission in our entire population. We have safe and effective vaccines that can do that. That's the aspirational goal I urge you all to focus on. It's the American way. Think big. We can eliminate hepatitis B virus transmission in our population. And that's why the NFIB supports universal hepatitis B vaccination. Thank you.
Thank you, Dr. Schaffner. We'll move on to Dr. Hoag.
Thank you, Dr. Lee. I have some practical questions, a couple of practical questions I'd like to ask that may require a response from our friends at CMS who are on the call or others. I really was compelled by Dr. Lohr's arguments in looking at the statistics. I think that it seems to me there's an awfully strong case for the less than 59-year-olds, and I do in fact support strongly the universal recommendation in that group. I'm not convinced of the marginal benefits that are evidenced on the slide that was previously on the screen in the people over age 60, and arguably the risk in especially the very old, those over 85, I would think would be very, very small. So I see the benefits at age 59 or less. I'm questioning whether the benefits are there. Regardless, whatever your decision is on this, I want to first ask maybe someone from CMS to comment on Medicare coverage for hepatitis B vaccine, because to this point, and for many, many years, hepatitis B was one of those specially accepted vaccines that allowed for coverage under the Part B as in boy benefit. And so it was covered there for patients who were on dialysis, and then subsequently that's been expanded a bit. I just want to verify that CMS's intention would be to, if this universal vaccination is adopted for people over 65 who are Medicare eligible, that the vaccine would in fact be covered under Medicare Part B as in boy. And then my second question, which is also payment related for probably someone else, is universal recommendations such as this, I think, compel under the Affordable Care Act private insurance providers to provide coverage, $0 first dollar coverage for anyone that's insured. My concern is that there's a large segment of those people who are at risk, that are the highest risk, as has been shown in the presentations, who are in fact uninsured. And we do not have a good program in this country for providing free vaccines like the VFC program does for children for uninsured adults. And what are the plans, if any, that CDC or HHS would have to try to ensure that there's vaccine available for those uninsured adults? So two questions, one for CMS, one for CDC.
Thank you. Ms. Hance, are you on the line? Do we have a representative?
I am, thank you.
Oh, great. Please go ahead.
Yeah. So the current Medicare Part B language is that Medicare Part B covers hepatitis B vaccines if you're at medium or high risk. And there are some instances identified, such as your risk increases if you have hemophilia, you have end-stage renal disease, you have diabetes, you live with someone who has hepatitis B, you're a healthcare worker and have frequent contact with blood or bodily fluids. but the language also identifies that there are other risk factors. So that is the current Medicare Part B language. I have to confess that I, being a specialist on the Medicaid side, feel uncomfortable speaking definitively for CMS that this would be covered under Part B with a universal recommendation. I have reached out to Medicare colleagues and am working to address that question, but I do not feel comfortable making that definitive statement for CMS. But the language that I read is the current coverage that we have for Medicare Part B.
Thank you. And I'm going to turn it over to Dr. Wharton to comment on vaccines for adults.
Thank you for the comment about the importance of coverage for the uninsured. We concur that that's important. And, that'll be a policy decision in the future.
Thank you. And let me go back to my screen. And I see Dr. Zahn's hand is raised. Dr. Zahn.
Great. Thank you, Dr. Lee. So I'm speaking this morning on behalf of the National Association of County and City Health Officials. And our association does support a recommendation for universal vaccination of all adults. And this is based on our local public health experience. In our jurisdictions, acute hepatitis B is public health reportable disease. And when our staff follow up with these cases, as has been noted by Dr. Wang today, we'll often find that the ill person had no previously identified risk factors, and despite previous contact with the healthcare system months or years previously, had not been offered hepatitis B vaccine. For us, even for confirmed cases, when we are talking with them, there's reluctance to report their risk factors due to associated social stigma, and that in turn makes public health investigations very difficult. Certainly understand the questions being raised regarding persons 60 years of age and older and utility of vaccination, but I would note we certainly see these cases in people 60 years of age and older. We certainly see cases in long-term care facilities and dialysis clinics, and I think Dr. Talbot's exactly right. I note that even a single case in those settings necessitates a pretty large public health response and a pretty large response from the facility themselves. So it's not a trivial issue. Finally, very much appreciate the point made by Dr. Bell and Dr. Lee. NACCHO strongly supports the need for continued and increased support for outreach to at-risk population. And we certainly believe that local public health should continue to play a role in leading that outreach to those high-risk populations who really need to proceed on multiple fronts. But our local public health experience does tell us that the universal adult vaccination recommendation is going to be vital to any successful strategy to contain HepB. Thank you.
Thank you, Dr. Zahn. Dr. Goldman.
Thank you so much. First, much kudos and applause to Dr. Wang and the entire work group for this presentation. As a private practicing physician who's seeing adult population, I am extremely in favor of this universal recommendation. I try to teach my colleagues nationally on how to implement vaccine programs, and the biggest barrier to implementation is how confusing and detailed these recommendations are. So streamlining it, making it universal and as easy to implement as possible is key to its success. So the fact that we've gone or would potentially go from all of these risk-based to a very simple universal recommendation will greatly improve, I believe, the uptake of the vaccine, especially when you consider a primary care physician not only has to manage the chronic illnesses, blood pressure, diabetes, hypertension, everything that they're dealing with, plus recommending screening on colonoscopies, mammograms, and learn a vaccine schedule. The more complicated it is, the harder it is to get all those recommendations in. And I would also point out the presumption of risk decreasing over the age of 60 or 65 is not necessarily accurate. There are many areas in Florida where the STD outbreaks are increasing in the geriatric population, the over 65. And a brief cursory database search that I did of Florida's reportable diseases showed that over 25% of the acute hepatitis B reported cases were over the age of 60 in this year alone. So I really think it is important to consider that the risk is, as previously stated, not always identified or reported, where I believe we're underestimating those at risk, and we're not making the recommendations as the way it should be. So this universal vaccine recommendation will help to decrease the incidence of hepatitis B. And then finally, a brief question about the recommendation, wondering, instead of the proposed language of all previously unvaccinated, would it be helpful to say all adults without evidence of immunity? Minor semantic point, but if we're doing a universal screening to see if they have antibodies, to see if they previously had disease, should we change that language as a consideration from unvaccinated to without evidence of immunity? Thank you.
Thank you, Dr. Goldman. I'm just going to warn people, I'm going to go a little bit out of order just because I see a couple of other members' hands raised, but I will come back to everybody. I wanted to go to Ms. Howell next because I know she perhaps wanted to respond to the registry question as well.
Yes, thank you, Dr. B. I do agree with Rebecca Coyle's comments regarding adult immunizations in immunization information systems. I just wanted to add a couple of other comments. One thing, or one area that is a gap in terms of having adult immunizations in our IAS is not being connected or not receiving reporting from federal systems, including Indian Health Services, the VA, and the Department of Defense. And so establishing connections between IAS and federal systems will be critical to ensure adults have a complete record of their immunization histories. Also, adults are very mobile, and so interstate data exchange between IASs is critical to ensuring adults have one central record of their immunizations to inform which vaccines they need in the future. I also wanted to add a comment. Many awardees use Section 317 vaccine to provide adults with who are uninsured access to vaccines. And so with a universal hepatitis B recommendation, I just wanted to state that Section 317 vaccine funding is limited. And so states awardees may or may not be able to include hepatitis B in their formulary for all adults who are uninsured unless there is an increase in that funding or allocation. And then I just had a question about the screening prior to vaccination. I'm just wondering if there's any data on the percent of individuals who don't have detectable antibodies but were previously vaccinated or infected, and if that data is out there. I know we get that question quite often with healthcare workers who were vaccinated but don't have detectable antibodies. Thanks.
This is Dr. Wang. We have understand there is a small portion of people who do have decreased immunity, but we know that after vaccination, but we know that overall Hep B vaccination is highly immunogenic, highly effective, over 90-95% effective long-term. Thanks.
Thank you. I'm going to check to see if Dr. Cotton, do you still have your hand raised? Okay. Thank you. Sorry. No problem. Ms. McNally.
Thank you. I am curious if there are any other countries with a universal recommendation for Hep B.
Thanks. This is Dr. Wang. That was of interest to the work group as well, and we presented in the grade and ETR back in September. We didn't find evidence of other countries pursuing this universal policy. What we do know is that we try to look at some subsets, particularly in the dialysis setting, where there's well-defined groups that regularly access care in designated locations, looking at universal recommendations from a certain perspective within that subset of risk factors. We know because they're a well-defined patient group with regular access to care, we know also that these parameters don't necessarily hold true for some of these other risk factors that you see on the screen, or many of the risk factors we see on the screen. And we can kind of, and along with also the parallels that we drew from other vaccine-preventable diseases, those were the examples that we rely on, short of having specific evidence from other countries that have done this before. Thanks.
Thank you. Dr. Schmader.
Thank you, Dr. Lee. This is Ken Schmader, American Geriatric Society. And for the record, AGS supports universal hepatitis B vaccination with no upper age limit for all the advantages presented on slide 19 in Dr. Wang's excellent presentation. I wanted to point out that what will happen in practice for very old persons or those who have limited life expectancy and their caregivers and their clinicians, they're going to make their own common sense decisions as to whether to follow this recommendation or not. Thank you.
Thank you, Dr. Schmader. Dr. Freihofer.
Sandra Freihofer, our American Medical Association, speaking as a practicing internal medicine physician in support of universal recommendation of hepatitis B vaccination. When I was a third-year medical student, I rotated through a hepatitis unit, and these were some of the sickest and most miserable patients I've ever seen, and I knew I never wanted to feel that way. And that was before there was any kind of hepatitis vaccine available. And as soon as a Hep B vaccine came out, I signed up for it. So I actually got the first generation hepatitis vaccine. And as has been pointed out, if you look at the list of risk factors that are on our screen, look at that first bolded area. Some patients may not want to reveal their personal risk factors, and they therefore may miss vaccination. I think Dr. Goldman mentioned some of the challenges we're seeing in those over 65 that are living in some of the assisted care facilities. We now have a vaccine that can prevent this suffering, and no one should endure the suffering I observed when I rounded on that hepatitis floor from something that's totally vaccine preventable. And I really do hope that ACIP will recommend universal vaccination for all adults, including older adults.
Thank you. Dr. Baker.
Thank you, Dr. Lee. I will spare you any personal anecdotes, but I do have one personal comment. As a former member and chair of ACIP, it is the mandate of the ACIP to make good, evidence-based health policy. A lot of the comments today are very true, and I would strongly, personally support Dr. Bell's comment that we do need good funding for all vaccine programs by funders. My comment representing the Infectious Disease Society of America is that the society members made up of leaders in public health, vaccine research, clinicians, advisors, and educators to the community and to policymakers, we strongly, as a society, support universal hepatitis B vaccination for many of the reasons mentioned, but not to exclude saying risk-based is a failed policy. The evidence is overwhelming. And in the era when we really would like to improve health equity, that's another strong case. Thank you.
Thank you, Dr. Baker. Dr. Zimmerman.
Rick Zimmerman, University of Pittsburgh Association for Prevention, Teaching, and Research. In my clinical practice, I do treat hepatitis C disease actively and work in a federally qualified health center. We do report our adult immunizations to the state registry. I see this idea of a universal non-risk-based as being very helpful in my inner city practice. It is most helpful in those less than 60 because of the number of persons who've been infected with Hep C and who have risk factors, diabetes, and it is hard to do that. I do note that there is somewhat of a diminishing return over 60, not to say there's none, but many of my patients have been in either aren't, to my knowledge, having any continued risk factors or have been vaccinated because they have hepatitis C or because they have been in a dialysis program. So I could see some advantages to phasing a universal recommendation, starting with the younger age group and then perhaps in a number of years extending that. Thank you.
Thank you. Dr. Long.
Yes, thank you. The examples that you showed us of the increase in immunization levels when universal recommendations were put into place are all examples of either doctor behavior that needs to be changed or a very clear-cut age-based recommendation is easier for doctors to understand, easier to explain to patients. But we haven't been given, in my opinion, any compelling evidence that for this behavioral risk of patients, which is multiple sexual partners and intravenous drug abuse, that this expensive American Band-Aid, I'll follow Dr. Schaffner's cue on that, that would really affect the group that we're trying to get to. I might be willing to give it a chance for those who are at the highest risk because of their age, that hopefully we would have some of those people come to care, or that we could find those people and it would be clear to immunize them. But I haven't heard the evidence that we should reach out to a group that is at low risk to themselves and to others and immunize them, because we know they would sign up, because older people generally do what they're recommended, and those that have routine health care would certainly have been immunized. But we still don't know that those older people who are still at their behavioral risk would have any compulsion to increase their health care that would get them immunized. So I'm still looking for that alternative recommendation.
Thank you, Dr. Long. Dr. Sineas.
Thank you, Dr. Lee. I am a new member of this work group, and I appreciate all the work that has been put into this over the past 5 years. As a busy primary care physician, I agree with everything Dr. Goldman and others have said. Simplification of the recommendations will help reach more individuals at risk. More importantly, I think that we have a great opportunity and a great potential to promote health equity among the groups that Dr. Wang showed that are disproportionately affected by Hep B. As far as the age cutoff goes, I agree with Dr. Sanchez that the age group above 60 is a very heterogeneous group, and then some may have more risk than others. And as others have said, that there are older patients who do engage in higher risk activities. So for those reasons, I'm in support of the universal Hep B without an age cutoff.
Thank you, Dr. Sineas. I believe we have gotten all the raised hands. I just want to confirm, Dr. Freihofer, Baker, Sineas, your hands are no longer up, right? And I see Ms. McNally.
Thank you. Dr. Lee, I just really want to comment that I've appreciated this conversation very much, and I'm leaning in favor of this recommendation as a universal recommendation because I'm really concerned about health literacy. I think this is a complicated disease to understand and to self-identify as having risk factors. I myself, during the course of this discussion, have Googled this, and arrives to a website for which has about 100 questions and answers for people regarding the overview, treatment, symptoms, et cetera, for Hep B. So I think it's complicated. I think it's another disease that disproportionately impacts minority populations. It can present without symptoms, and it can develop into chronic and debilitating diseases. And for that reason, I do think that I'm in favor of a universal recommendation on this. Thank you.
Thank you, Ms. McNally. Okay, I don't see any additional hands raised, and I'm personally struggling because I agree with all of my colleagues' comments. So we will actually, what I'd like to do is just take a short 5-minute break so we can just revisit the vote language based on the comments from today, confirm that before we move forward. So 45 minutes after the hour, we will reconvene. Thank you. Thank you, everyone. It's now time to reconvene the ACIP meeting, and we wanted to just make sure we took a look at the wording, given the suggestions and the conversation we just had. We're going to put this proposed recommendation up, and I'll actually ask Dr. Wang to go through it and provide the rationale for this, and then we can talk about, the opportunities for amendments if need be.
Hi, this is Dr. Wang. Thanks, Dr. Lee. So based on the discussion, we've revised the language slightly to all adults are recommended to receive hepatitis B vaccination. And this would allow for discussion of screening considerations in a separate piece. So thanks.
Thank you. Yeah, and I think for me personally, it also just allows us to know that if you were previously infected, that may or may not apply to you, but clearly the intent is for the unvaccinated. We just don't routinely have recommendations with the word unvaccinated in there. So this would provide the flexibility the work group needs to incorporate additional changes as we go forward. So this was a proposed recommendation put forward by the work group. I'm going to ask if any of the voting members would like to make a motion on this particular recommendation.
Grace, you have 2 hands up.
Sorry, I'm a little delayed right now. Dr. Lair.
I would like to make a motion for an amendment to change this recommendation to all adults less than or equal to 59 years of age are recommended to receive hepatitis B vaccination.
Dr. Lair, we're going to actually ask for a motion on this proposed recommendation. If we don't get a motion, we can change it. If we get a motion, you can propose your amendment.
My apologies. Thank you.
No worries. Okay, Dr. Talbot.
I would like to vote on this proposal as worded. I'd like to make a motion.
Thank you, Dr. Talbot. So it's been moved to accept the proposed recommendation on the slide. Would anybody like to second the motion? Ms. Bata.
I second the motion.
Okay. It's been moved and seconded that the vote be on all adults are recommended to receive hepatitis B vaccination. Would anybody like to, for example, thank you, Dr. Lair.
I'd like to make a proposed amendment to the recommendation stating all adults less than or equal to 59 years of age are recommended to receive hepatitis B vaccination.
Thank you. Would anybody like to second that motion? Dr. Long.
I'll second that amendment.
Thank you. So I'm going to get this language wrong, but it has been moved and seconded that there be an amendment on the initial motion that now states, and actually we will make the edits on the slide so we make sure we are all voting on the same amendment. But all adults less than or equal to 59 years of age are recommended to receive hepatitis B vaccination. One moment. So we will vote on the amendment first. Once we have clarity on whether or not the amendment passes or not, then we can move to the next stage. We will not do the full vote until after public comment. Dr. Alt, did you wish to make a comment?
I was going to ask about the first thing you said, but I also wanted to clarify from Dr. Lair or anybody else, you know, are we going to preserve the above 60 recommendations? Oh, you have that. Never mind. I'll be quiet.
Thank you. And if there's any minor wordsmithing that needs to happen, we'll allow that to happen. But we want to make sure the intent of the committee is carried through. I actually see some hands raised, so I will invite discussion on the amendment at this time. So I'm going to move to the voting members. Dr. Talbot.
I was wondering if it wouldn't make sense that we go ahead and vote on the regular one at that time, and if it doesn't pass, then we vote on the amendment, so that everyone has a chance to vote for both if needed.
I have been informed that per Robert's rules, we need to vote on the amendment first before going back to the main motion. If the amendment passes, then we would amend the main motion. If the amendment fails, we go back to the main motion, and then we would vote on that main motion. Please correct me if I got anything wrong. Okay. Thank you. Dr. Chen. Dr. Chen, did you want to offer additional comment?
Sorry, I think I'm having computer problems. I thought I lowered my hand.
Okay, thank you. Dr. Brooks.
Yes, I would like clarification. Were we to endorse or vote for this amendment, what is this saying regarding age 60 and up?
Yes, I can pull up just so I can do visually. If we add another.
Thank you for your patience. We want to make sure we get the wording correct, so they want to move to the correct slide.
Sorry, Dr. Brooks. So visually, this is what it would look like. The red text has been wordsmithed a little bit. We took out the previously unvaccinated for hepatitis B as just discussed, but otherwise, the current risk-based strategy, risk-based vaccination recommendation would be retained for everyone above age 59 years. Thanks.
And so therefore it would be no, other than the change in the wording, it would be no change in the present recommendation.
For those above age 59, yes.
Which is risk-based. I mean, right, for 60 and up, right, risk-based.
Correct. Thank you.
So just to clarify, so universal 59 and younger, risk-based 60 and older. Okay. Thank you. Dr. Long.
Yes, the first was your grammar point. It has to be 60 and above because the less than or equal to is 59 days and 59 years and 364 days. So the second should be 60 above. But I would, if we get to that, and I don't know that this is the right time, I would say I would have two categories for the 60 and above, and one would be a should, which are all the previous, and everybody else would be a may. So there would not be a requirement to declare that yourself in a risk group. And we haven't discussed that language at all, but I would make the 60 and above much less restrictive than it currently is. the risk-based.
Thank you, Dr. Long. Give us a moment to process that information, and we will come back to it. Dr. Daly.
Yeah, thanks so much. So, first of all, I appreciate the discussion so much. It's been very helpful to me. And Dr. Wang, I appreciate you explicitly sort of laying out the pros and cons of each strategy, because I found that very helpful. I also greatly appreciated hearing from the liaison members, including local public health, who said, we need to implement this. So I am more in favor of an upper age limit, but I would support universal if that's where we land. I think if we did land on an upper age limit, then I feel like we focus on that, we do the best job we can, and if we find that rates are rising in those over 60, if we find that vaccination rates are lagging in those over 60, then I really do think we can revisit this. Thanks very much.
Thank you, Dr. Daly. Dr. Paling.
I wanted to support Dr. Long's comment about adults 60 and over may receive universal hepatitis B vaccine. And I do think that may is really important. As I'm watching insurance companies, they create all kinds of quality metrics for us. And, it doesn't make sense to me that if you're serving a population of over 80, you would be judged about your vaccine coverage. And I'd like to allow the physicians and the patients the opportunity to discuss that and be able to make decisions. So I'd like the adults over 60 with a may. Thank you.
This is Dr. Wang. Just to note that there is already permissive language for the not at risk but want protection from hepatitis B for this older age group.
Okay, so I just
For the immunization schedule itself. Sorry, go ahead.
I think we could reword it and make that more clear.
So it sounds like the current immunization, I just wanted to restate this so I'm clear too. The current immunization schedule allows for individuals to receive a hepatitis vaccine at any age. We have a very specific risk-based recommendation in place now. The current amendment to the original motion asks for universal hepatitis B vaccination for 59 and younger. We continue to promote a risk-based recommendation for 60 and older. However, anyone can receive a hepatitis B vaccine per our immunization recommendations.
That's correct. Thank you, Dr. Lee, for restating that.
The request is to what it says.
Okay, so the request is then to add a clarification here so that we're all voting on the same thing, that consistent with the current immunization schedule, any adult who wishes to receive protection may receive a vaccine or something along those lines. We'll make sure it's consistent with what the adult immunization schedule states, but we have that in the background. Does that answer your question, Dr. Long and Dr. Paling? I'm glad you asked.
Yes.
Thank you. Okay. I see. Okay. Dr. Sanchez.
Thank you. I would favor an upper age cutoff as well, for the reasons that have been mentioned. But, I just think that the 59 again is too young. My concern about making it a universal recommendation is that there's going to be 80, 90-year-old people who don't need this, and those may very well be the ones who are getting it because they're seeing their physicians more frequently. So I know that this 59 is ingrained with the diabetes and stuff, but I would favor a more a higher cutoff. But then having language that those 60 and older may get vaccine, I think that would be a way out of that as well. My concern that just anyone can receive it would be insurance coverage, and whether they would have to pay just because they wanted, whereas whatever carrier they have or Medicare, I'm not really sure what they pay if it's just without a known risk factor.
So, Dr. Lee, this is Amanda. I was wondering if I'm thinking that maybe we should vote on this amendment with the clarity that during lunch and during the breaks, if this amendment passes, the voting language will also, the vote that you do this afternoon will clarify that adults 60 years and older can also be vaccinated, and we'll make sure that it aligns and it continues to be on the immunization schedule. Does that seem reasonable?
That sounds very reasonable to me. So why don't we keep moving forward? You might be stuck with us for dinner tonight, everybody. All right, Dr. Talbot.
I was hoping to Dr. Daly's comment. Dr. Wang, sorry. Now I can get it to shut up. Okay, so Dr. Wang, could you please show or discuss the immunization rates of those over 60 that are high risk currently? So I think there's a large number in that group, and because it's not universal, they're not being immunized. So I think it would be helpful to see how true that is or is not.
Hey, this is Dr. Wang. Just going back to this hepatitis B vaccination coverage decrease in older adults with greater or equal to one risk factor. So these are just the risk factors assessed. That's diabetic, has chronic liver disease, or traveled to hepatitis B endemic country. So the 60 plus, so as ages get older, particularly at the 50, 59, 60 plus, these are all people with at least one risk factor, but they're still not well covered. And then I'll also just reiterate that to expand the pie, this is just one piece of the pie. The initial premise is that with the yellow highlighting, that's a whole chunk of the pie that because of the very nature of this risk-based strategy recommendation in place, we've come to kind of the end of the line of marginal utility, and we can't find these. There's challenges in finding people who have risk data missing or no risk identified. So, thanks.
So I think briefly what we're saying is that 80% of the people over 60 who have a high risk factor are not getting vaccinated under this risk-based recommendation. And so if we don't make it universal for them, it is likely to be that 80% of those over 60 who are recommended to get vaccine will not get vaccine.
Okay. Thank you, Dr. Talbot. Again, making this decision hard for me. Okay, Ms. Bata.
Yeah, I appreciate a lot of the points that are raised, and I appreciate the fact that that there are individuals, very senior individuals, who probably have no risk factors for acquiring hepatitis B. But having seen the lifespan of the hepatitis B recommendations in my work in immunizations, risk-based assessment isn't working. And I have my own personal anecdote in that the pediatrician recommended against vaccinating my children because they weren't at risk, without even understanding the risk factors that they had. And so we're missing them. And as Kip said, we will miss 80% of those 60 and older. And we are doing a really miserable job identifying those at risk. And with a maybe vaccinated, again, that doesn't, it doesn't set an infrastructure to proactively assess risk. And so it just isn't addressed. So I'm trying to reconcile universal adult hepatitis B vaccination with situations in which there really is absolutely no reason to vaccinate someone who might be 85 and doesn't have a lot of interaction or social life that could change. Anyway, I'm very reluctant to see an age cutoff. I'm very reluctant about us hanging on to risk-based decision-making for this vaccination because in the past 30 years, it has not been working. Thank you.
Thank you, Ms. Bata. Dr. Daly. Can you speak up, Dr. Daly?
Sorry, can you hear me?
Much better, thank you.
Sorry. I wonder if we could pull up that slide of vaccination coverage by age among those with high risk. Because I found this compelling too, that the risk-based strategies aren't working in adults over the age of 60. I mean, I really did. And if we land on universal with no upper age limit, I'm going to support it. But I was just trying to think about how big is that group relative to the other groups. And I think the incidence is 0.6 in 100,000, if I'm getting that right. And that's lower than other age ranges, but it's not hugely lower than other age ranges. And so that's why I find this decision difficult. I was trying to think about not just what the coverage was, but how big that group was. And Dr. Wang, maybe you could help me if I'm getting that incidence in 60 plus correct. Thank you.
So this is Dr. Wang, that's correct. Thank you.
Thank you. We'll move to Dr. Lair. Wait, no, I'm confused here. Hold on 1 second. Dr. Alt.
I just wanted to say that, I've been looking at this data quite a bit as the working group chair, and I can see both sides of this argument. However, this slide that we have up, slide number 8, tilts me over towards the universal recommendation and no age limit. So that's how I got to the point I'm at. And so I'm basically agreeing with what Dr. Talbot just said.
Thank you, Dr. Alt. Dr. Lair?
Well, I appreciate all my colleagues' input, and I think that I could go either way, and I'd be happy with the universal. However, I do believe that we have a responsibility to use resources well. And when someone says that we can't allow one case, it does come down to how much effort and cost would that one case take. If that cost was $10, we'd all do it. If that cost was $1 billion, we wouldn't do that. And so we all have in our head a point of diminishing returns at which you would say, this is no longer a good national policy. And if we're going to try to vaccinate everybody to get rid of every last case of something, I don't think that's a good national policy. So that's one of the major reasons why I'm going into favor of an upper limit. And that's because I think that the resources and diminishing returns are compelling. Thank you.
Thank you. Dr. Bell.
Yes, apologies for beating this slide 8 to death, but I just want to make one other point in addition to the denominator, that is that it's a small proportion of a small number. I also just want to remind people of Dr. Long's point, which is that what we're really trying to prevent here is chronic HBV infection, cirrhosis, and chronic liver disease and cancer. And if someone acquires hepatitis B at age 65, while they are at a small risk of fulminant acute hepatitis B, the likelihood that they're going to develop some of these sequelae that we're trying to prevent is pretty low. Now, granted, they might transmit, and there's certainly other issues, but I just want to remind people about what the outcome is that we're trying to prevent and the fact that it takes quite a while for it to develop. So that's just another thing about looking at this slide and interpreting, what it's saying.
Thank you, Dr. Bell. Dr. Paling.
All right, so first of all, I'm listening intently to all of my colleagues and appreciate the robust discussion. Dr. Daly was referring to the incidence per 100,000. When I added up the numbers in that in that slide, it came to a total of 7.2 per 100,000, with 0.6 among persons 60 and older. And so 92% of the disease burden occurs in less than 60 years of age. And so that's one of the things that is swaying me, and also what I'm trying to prevent is the long term. I do want to reiterate a point that Dr. Bell and others, and I believe you've made strongly about supporting this recommendation. If I understand the conversation correctly, about 60% of adult data is in an immunization system. And what is critical when we look at this recommendation is actually knowing whether or not someone's vaccinated. That includes childhood or adult. And so I want to emphasize the importance of investing so that all immunizations across the age group are in there. And I think we can get there relatively quickly because electronic medical records are present. It's going to take some work across the states, but I think it's an important point to emphasize. Thank you.
Thank you, Dr. Paling. Dr. Long.
Yes, if you'll leave this slide here a little longer. So this 20% immunized only over 60, that's doctor behavior. That's doctor behavior. That's not risk behaviors for hepatitis. You see what the underlying conditions are. And I have to believe if we make this a universal recommendation for the majority of their patients, they're hopefully more likely going to get it. And shame on the doctor who has a patient with chronic kidney or chronic liver disease who doesn't get hepatitis B vaccine. And the second thing is the pie chart that you showed us, the 2/3 did not have evidence of risk behavior. I have to believe that that full third that is missing data are the people who show up with hepatitis B who aren't in the healthcare system and wouldn't be the group that would come to be vaccinated. So I think, again, although we all have the same intention, we want to protect as many people as we can. We have to be sure that what we're going to do is going to protect the right group.
Thank you, Dr. Long. And since we are well beyond our time, I'm just going to ask if Dr. Middleman and Dr. Goldman could just make a very brief comment. Dr. Middleman.
Oh, thank you. It's Amy Middleman from SAM. I just have two quick questions. One is the way it's written for both. I just want to make sure. I know there's been a discussion about previous vaccinations, but having all adults recommended to receive HepB vaccination may not be clear that those who were vaccinated as neonates or teens would not then get another vaccination. So I know this could be addressed in the clinical considerations, but I think it's a little bit confusing the way it's stated. The other question I have is related to the timing of the recommendations for hepatitis B screening. Would it be done before vaccination, after vaccination? And this may not be the right venue, but many people lose their surface antibody with time, but still respond well to an anamnestic response to booster dosing, implying they still have immunity. So I just wanted to make sure that there weren't people getting screened who had been vaccinated as a child who now are surface antibody negative, but then get vaccinated when that may not be necessary. So, thank you.
Thanks for that. This is Dr. Wang. Those points are discussed by the work group, and points taken. We can do the clinical considerations where we can go more into depth about the folks who have been previously vaccinated as children. As for the timing of the screening, like I said, we focus primarily on the vaccination piece, but we recognize that the work group does not want screening to be a barrier to vaccination. Now, there is existing pre-vaccination testing language in the current guidelines that we can draw from also in clinical considerations. Thanks.
Okay, thanks. And Dr. Goldman?
Thank you. I'll be real brief. Two important points. One, while it's important to consider the global health costs and the system costs, I'm always concerned about what is going to help my patient in front of me at that moment right there, and we need to reduce individual risk. And number two, while this age-based recommendation is not acceptable, is that we are missing patients. It's not doctor behavior. We are not doing the patients are not willing to admit their risk. Having a 65, 70-year-old tell you their sexual history, they're not always going to be as upfront, nor do they tell you about how much alcohol they're using. So it's not so much doctor behavior as identifying them, it's that the patients are not always as honest or forthcoming with their history. And we are seeing a lot of risk in the over 60 population that are not getting the vaccines that they need because they are not telling us their risk. So we really need to be cognizant of that and make this universal to decrease the disease in the individual patient. Thank you.
Thank you. Okay, so we are going to now move to what is on the slide, which is the amendment to the original motion. You are now voting on whether or not you agree to accept the proposed amendment to the original motion as written on the slide or not. And we can then go from there. And I'm actually going to do this completely upside down. I'm actually going to go first and then go in reverse alphabetical order just to throw everybody off. So Lee, no conflicts, yes. Next is Lair. Dr. Lair.
Lair, no conflicts. I vote in favor of the amendment, so yes.
Thank you. Dr. Cotton.
I'm still thinking about it. Can we come back to me?
I haven't done that before, so I'm told I can do that. Dr. Daly.
Daily, no conflicts, yes.
Dr. Sineas.
Sineas, no conflict. And I'm confused. If I vote for this, do I then also get to vote for the universal no age cutoff?
No, if you would prefer the universal, you would vote no to this because you would want to get back to the original motion.
All right, then Sineas, no conflicts, no.
Thank you. Dr. Chen.
Wilbur Chen, no conflict, no.
Thank you. Dr. Brooks.
Excuse me, turn my camera on. Dr. Brooks, excuse me, no conflicts, yes.
Dr. Bell.
Bell, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, no.
Dr. Alt.
Alt, no conflicts, no.
Dr. Talbot.
Talbot, no conflicts, no.
Dr. Sanchez.
Sorry, Sanchez, no conflict, yes.
Okay. Dr. Paling.
Paling, no conflict, yes.
Ms. McNally.
McNally, no conflict, no.
Dr. Long.
Long, no conflict, yes, with the provision that when the amendment was made, this bulleted part wasn't there, and I don't approve the wording of the bulleted part. I assume if this passes, we will flesh that out better.
Yes. I'm confirming here that the CDC team will edit the wording before the full vote. Dr. Cotton.
Camille Cotton, no conflicts, no.
Dr. Lair, did I get you? I did, okay. All right, so all members have voted. I see 8 yes, 7 no. So the amendment passes. And the proposed motion that would move to the full vote with edits to the language as requested will go after the public comment session. That was a very close vote. Okay, thank you, everybody. With that, I think we should take a break. 10 minutes?
Dr. Lee, excuse me a minute. I'm sorry. Can you state the vote again? I'm sorry.
Sure. It was 8 yes for the amendment, 7 no against the amendment. So the yeses have it, it's majority, and the amendment passes. So what will go for the full vote is all adults aged less than or equal to 59 years are recommended to receive hepatitis B vaccine. Adults 60 and older will continue to follow current risk-based recommendations. And with the addition that in the adult immunization schedule, anyone is allowed to receive hepatitis B vaccine if they wish to have protection. Any additional questions or clarifications from the committee? We are running quite far behind. That is okay. I think we needed to have this discussion today. I'm going to propose we take a 10-minute break. I am very sorry, 10-minute break. Let's plan to convene. Actually, let's make it like a little bit longer. So 20, I can't count, 35 after the, let's make it 35 after the hour. So 14-minute break. All right, thank you, everybody.